So today we will discuss something about epidural injection, that too particularly the transforaminal epidural injection, the infraneural approach or Kambins approach. So this is what we are going to discuss today. So it all started with caudal epidurals long back when fluoroscopy was not there. So there the landmarks were palpated and people used to do caudal epidural, though the pathology is somewhere higher up at L4, L5S1. So in those cases we used to give huge volumes of steroid mixed with local anesthetics, and we are not sure whether this drug will go up to the anterior epidural space at the exact site of pathology. But of late the fluoroscopy has come into picture. Nowadays the targeted injections are being done by all the pain physicians, whether is anesthetist, an orthopedic spine surgeon or a spine or neuro or neurologist, anyone. So nowadays everyone are doing fluoro guided targeted injections in and around the pathology. So we will discuss about transforaminal epidural injection. So what happens, what is the difference between the interlaminar epidural injection and transforaminal? Interlaminar epidural, you are injecting the drug in the posterior epidural space. So whenever we inject the drug, they come out of the intervertebral foramen, and when the nerve root is devoid of the dural cuff, when it becomes bare, the drug affects on the nerve root. But the drug may or may not go into the anterior epidural space to have its effect on the pathology. The pathology is maybe annular tear, maybe a disc herniation, or either it is an extrusion or protrusion or sequestrated disc. So that's why people are resorting to giving a transforaminal epidural. So what are the indications for transforaminal epidural injections? Number one, as you all know that once the conservative management fails in case of any disc herniation, if it is acute or subacute, either in the form of NSAIDs or physical therapy, you can subject the patient to epidural injection. Number two, we can try a failed back syndrome patient also who has got a lot of hardware, still patient is complaining some radicular symptoms, still patient is complaining some back pain. The third is, if there is any discogenic pain also, you can give epidural injections. We can also use for herpetic neuralgia involving the lower limbs as a single shot epidural injection also. Contraindications. What are the contraindications? Number one, patient is not giving a written consent for the procedure. If patient has got a local infection at the site of the procedure, any systemic allergy to the dye or the medications used for epidural, a patient has got the so-called any bleeding disorders, because it can land in a epidural hematoma, and there are some other relative indications also. So let us go into the procedure proper. So now I will discuss something about how do we perform transforaminal epidural. If you see here, this is a skeleton of a human being. So you can see this is head and side, this is tail and side, this is patient's right side, this is patient's left side. Now I will show you how to perform a Kambins approach for epidural steroid injection. So if you look at here, this is head and side, this is tail and side, and first and foremost we will place the patient prone on a pillow, and if you look at here, this is L1, L2, L3, L4 and L5. So here first we will take a AP X-ray shoot, then we go oblique. See here, if you see, this is the interlaminar window. If you go through this, it is called as interlaminar epidural injection, but what I am showing is a transforaminal epidural. So you tilt the C-arm almost 30 degrees oblique. You see, try to see till what extent you will tilt the C-arm. See, now you see, this is AP view. You look at the spinous process. Spinous process is exactly in the center, equidistant. If you try to measure from pedicle to spinous, the distance is same in fluoro. But as you move oblique 30 degrees, almost this spinous process is getting aligned See, this is SAP, this is IAP. So it is aligned along this one. And you try to look at here, look at the here, you see, you try to see here, this is SAP, you are getting a Scottish dog appearance. The Scottish dog here, you see, if you see, the nose is formed by the transverse process, the ear is formed by the SAP, and the forelegs are formed by the IAP, and the uncolored area is nothing but the pedicule. So this spinous process is almost pushed to the opposite side. So this is Scottish dog appearance, and the tail is formed by the opposite side SAP, and hind legs are formed by the opposite side IAP. So our area of interest is exactly lateral to the SAP. So we try to put the needle like this, and we go end on view from here to the anterior ventral aspect of the epidural space. See, so this is the exiting nerve root. For example, if you presume this is L3 L4 space, then this becomes L3 exiting nerve root, and here comes L4 traversing nerve root, which comes under the L4 pedicule. So the almost you will land somewhere here. So if you look at here, the boundaries of foramina. So in Kambins approach, what you do is you go almost on the lateral aspect of the and slip into the intervertebral foramina, exactly just posterior to the disc herniation, so that you are addressing the pathology as well as the nerve irritation also. So both things are addressed in transforaminal epidural. So the target area is nothing but the SAP, the superior articular process, lateral border, and you slip along the SAP, the lateral border to the anterior border of the SAP. That's a technique. This is called as infraneural approach because it is below the nerve root. If it is subpedicular approach, it is called as supraneural. You will land somewhere here. This is a area. So the other approach is supraneural approach or subpedicular approach. This has got only two indications. One is for diagnostic nerve root block, wherein there is a doubt in the diagnosis, the signs are not elicited properly and symptoms are still there. Then for diagnosis purpose we use it for nerve root blocks, the subpedicular approach, as well as in case of Feldbach syndrome, if you want to do a pulsed DRG RF, we try to use the subpedicular approach. These are only two indications, but if you want to do a transforaminal epidural for the sake of the disc herniation, the Kambins approach is used. This is a case of L4-5 disc herniation radiating to left lower limb. Patient already had conservative management in the form of physical therapy, NSAIDs, muscle relaxant, but he is not relieved of the pain. Now he has opted for epidural injection. We are going to do a transforaminal epidural injection. That's an infraneural technique, or otherwise called as a Kambins technique or suprapedicular approach. What we are going to do, show you. This is a case of L4-5 lumbar PIVD radiating to left lower limb. You can see here there is a paradiscal acute disc herniation. So we are going to do a Kambins epidural injection right now. Standard ASA monitoring is mandatory. Patient is connected to BP as well as pulse oxy, because sometimes patient can go into vasovagal shock because of the local anesthetic. So it is mandatory to have a ASA monitoring. Patient is connected to even oxygen. So almost 2 liters of oxygen is put through nasal prongs. Patient is conscious throughout the procedure. No sedation should be given, because in case if there is any inadvertent intradural puncture or a needle prick to the exiting or traversing nerve root, there will not be any feedback in case if you give any sedation. So patient should be conscious. So if you see the position here, patient is positioned prone on a pillow, any pillow, no issue. but it is almost looks like a Wilson frame. It's a soft cushion pillow, so that definitely the lumbar spine has got some lordosis. So we are making the obliteration of those lordosis and we are making little kyphosis. Definitely there is lordosis. So by putting this cushion under the abdomen, so we are trying to reduce the lordosis, obliterate the lordosis, or we are making little kyphosis, so that you don't require too much of wigwagging the 𝗖𝗘𝗧𝗔𝗡𝗣. That is a advantage, and patient is conscious. You see here, oxygen is connected. Patient, yeah, he is speaking to me. So that particular area where you want to do, you are going to do scrub and drape that area. And if you see here, in this case, the patient's right hand is this side, left is the other side. So 𝗖𝗘 should be placed exactly on the side where we are doing epidural injection. That is mandatory. So ergonomically, you should stand exactly opposite to the fluoro, and since 𝗖𝗘 is your eye, since we are doing at a coaxial view or end-on view or tunnel view, so 𝗖𝗘 is your eye. So you should stand exactly opposite to the 𝗖𝗘, so that you know this is ergonomics, and there comes the monitor, so that you can see the monitor and should be opposite. Since here in the patient we are doing on the left side, 𝗖𝗘 is also on the left side, monitor is also on the left side, and you are standing on the right side. So this is mandatory. I tell you why. Number one, if you want a 30 or 35 degrees, you can take it. For example, if the 𝗖𝗘 is on the right side of the patient, you cannot go beyond 30 degrees. So there comes the problem. That's why the 𝗖𝗘 should be there exactly on the side where you are doing it. So this is part of positioning. Yeah, if you see here, this is the ornamentarium which is required for an epidural injection, transforaminal epidural, that is infraneural approach. If you see here, you got 2 Tohis needle. I don't use these Tohis needle for the procedure, but I have used them as a radiological markers in order to reduce the radiation. I spill 2, 3, 4 radiological markers to know exactly the target. So I am keeping away this, and this is 1% lidocaine, which is preservative free. Normally the 2% xylocaine or lidocaine which is available in the market has got a 𝗦𝗘𝗘𝗣 as a preservative, but this is a preservative free. This is nothing but xylocard, which most of the cardiologists will use. It is available in 2%, but I made it into 1%. I have taken almost 2.5 cc of 2% xylocard and I diluted with saline. I made it 5 cc. This is for local infiltration. You see here, this is a 26 gauge needle, hypodermic needle, and here comes the needle. The needle is done, the procedure is done with the help of 22 gauge Quincke's needle. If you see here, so we are going to do in coaxial view. So you look at here, there is a slot here, so the needle is beveled down, so we are bending the needle tip to the opposite side of the slot. Look at here, the slot is up, so I bend it down. I will tell you the advantage of bending the tip. This is purely in order to steer the needle to the target area, because repeatedly you try to pull out to the target area, push it, you will end up in too much of radiation. So this is the second one. Third is this ipoic dye. It is 350 milligrams per ml. This is non-ionic contrast which we are going to use it, and this is nothing but a 0.2% ropivacaine with dipomedrol. You can use either particulate or non-particulate, but the safest thing above L3 vertebral body is non-particulate, that is dexamethasone. But if you are giving below 3, it is up to you. You can use triamcinolone, you can use methylprednisolone, or you can use dexamethasone. All are the same efficacy, there is no harm. And here comes the saline. We even give saline purge in order to dilute or flush away all the inflammatory markers. The procedure proper is first take a AP shoot, so that in AP shoot the spinous process should be equidistant from both the pedicles. The pedicle to spinous process on either side, the distance should be same. Otherwise, you should suspect there is some tilting of the table, or there should be a problem that the 𝗖𝗘 is not positioned exactly at 0 degrees. but here it is placed at 0 degrees. So if you see here, we are interested at this is L4 body, this is L5 body. If you look at the pedicles, the spinous process is not equidistant. On the right side, the distance is more when compared to the left side. What does it infers? It infers that the table is tilted to one side. So instead of asking the technician to make it -5 or +5 degrees, because every time when he takes a APV, you have to remember. Sometimes the technicians may not be that smart to remember. So it is better that you tilt the table to see to that the spinous process is equidistant from the pedicle. That is number one point. Now if you see here, look at here, this is L4 body, this is L5 body, this is S1. If you see the pedicles are equidistant from the spinous process. How it was done? It is not by tilting the CM. Instead, we have tilted the table. This is the first point which you have to do. The second point is squaring the vertebral bodies. You see, if you look at here, the lower end plate of this L4-5 disc space, you see, the lower end plate is almost square. It is appearing as a single line, not a double shadow, because we have put a big pillow so that the lordosis is almost obliterated. That's why we could have get a beautiful squared end plate. That is number 2. And number 3 is an oblique 30 degrees view of the fluoroscopy in order to get a Scottish dog appearance. So usually for L5 S1, L4 5, we take almost 30 to 35 degrees. There is no hard and fast, it should be 30 to 35 degrees. Only thing is we got to tilt to such an extent that the spinous process which is in the midline should be pushed to the opposite side so that it will be in line with the SAP and IAP. That is number 1 point. And number 2 point is the same side, the ipsilateral side, the tip of SAP should stand exactly below the 6 o'clock of upper pedicle. That is number 2 point. These are the end points for obliquity. So it all depends. When as you go at higher levels of L1, L2, L2, L3, L3, L4, so the requirement of obliquity will get reduced. So that is the first point. Yeah, for transforaminal fluoroscopy we require AP shoot, oblique and lateral. This is oblique. We have placed almost 30 degrees. There is no hard and fast that arbitrarily it is made as 30, but you can wigwag the CM to 35 and 25 to see that I said already the spinous process should be pushed to the opposite SAP IAP junction. So now you see the CM is placed almost 30 degrees. Sometimes you may require 35 degrees also. So if in case for this patient, since we are doing on the left side, I place the CM on the left side. Just imagine if I would have placed the CM on the right side and I want 35 degrees, it is not possible. As you know, there is a restriction. You cannot make it 30 to 35 degrees that side. So that is a problem. So if you see here, this is L4 vertebral body, but if you see the lower end plate of the L4 vertebral body, there are 2 lines appearing. One is this, the other is this one. So it is not squared. What does it mean? The lower end plate should be almost parallel to the X-ray beam. So the anterior end plate and the posterior end plate are not in line with the X-ray beam. So what you have to do, since it is L4-5 disc space, we have to wigwag the CM little cephalad. Now I will make 5 degrees cephalad and show you the image. Degrees obliquity and little. Now my people, what they have done, since the end plate was not squared, this is L4, this is L5, this is S1. So we are doing it L4 and L5 trans-Kambins approach. So the L4 lower end plate is not squared. So our people, what they have done, they have done little 5 degrees cephalad tilt. So in spite we have put a pillow under the abdomen, we have obliterated the lumbar lordosis. Still there is some amount of lordosis. That's why the cephalad tilt of the CM has been done by my assistant technician, as well as there is an obliquity of almost 30 degrees. So whether it should be 30, 35, 25, I told you, you see the spinous process which should be somewhere here, it is almost push along the line of SAP and IAP. This is a spinous process. So, and the end plate is squared. This is a final position target. So where is our target for Kambins? epidural injection. Where is our target for subpedicular, that is safe triangle approach? So you look at here, there are two needles, two epidural needles being placed. If you look at here, before that you should appreciate what is Scottish dog appearance. You see here, look at here, this is the Scottish dog appearance. I am showing you the Scottish dog appearance, beautiful image of the Scottish dog appearance. You see, even below also you can see, this is the nose of the Scottish dog. It is formed by the transverse process, and the face is by the pedicle. You see, this is a pedicle, and the ears are nothing but the SAP. And if you see, this is the neck area. If there is any lysis, spondylolysis, then you can see a break in the neck. And you see, this is the body, and the forelegs are formed again by the IAP, and you see the hind legs are formed by opposite side IAP, and the tail is formed by SAP. So in all pain procedures, you should be in a position to appreciate the Scottish dog appearance. If you can appreciate Scottish dog appearance, you can do a subpedicular approach, or otherwise called as supraneural approach, or you can do a suprapedicular approach, or Kambins approach, or infraneural approach. So these are all the names given to this procedure. Apart from that, you can also, if you appreciate the Scottish dog appearance, you can do a dorsal ramus, the middle branch from the dorsal ramus. You can block it, or you can do RF, or you can go inside the disc to do intradiscal procedures also. So for Kambins approach, where is the target area? Look at the SAP. This is the pedicle. The birthday cap above is the SAP. Just lateral to the SAP, exactly, you just see lateral to SAP is the docking area, and we are going under fluoroscopy a coaxial view, that is end-on view, tunnel view, wherein the tip and hub should be visible as a dot. So you see the end plate is squared, the spinous process is pushed to the opposite side, so we no more require more than 30 degrees or less than 30 degrees because it is already pushed. And you see exactly the tip of SAP is sitting exactly at 6 o'clock of the pedicle above. That's the final position. So how do you know the final position? Whether it's 30, 35 or 25? These are the things which you have to see. Spinous process should be pushed opposite, and ipsilateral side, the tip of SAP should below the 6 o'clock of the upper pedicle. Now we are infiltrating the local anesthetic, 1% lidocaine after scrubbing and draping. So scrub is mandatory, as if you are doing a surgery you are supposed to do. There is no shortcuts in the procedure, because sometimes a Kambins approach can land inadvertently inside the disc. So a small skin tack, if it is pushed inside the disc, it can cause discitis. So you are supposed to do proper scrubbing before doing the procedure. It is no short than a surgery. So there is no confusion. This is cephal end, this is caudal end, that is left side of the patient, this is right side of the patient. Fluoroscopy at 30 degrees oblique and tilted 5 degrees cephalad, and we have placed 22 gauge Twinkies needle. The tip is bent to the bevel end side. Now I am placing my index finger here and lifting the needle after giving local infiltration, and my guide is the fluoro. So ergonomically I am opposite to the fluoroscopy, you see, so that I can watch in the monitor what I am doing. And this is my eye, bone is my friend inside, and my eye is the fluoroscopic beam. Now you see here, this is L5 pedicle, and this is SAP of the L5, and this is L4. You see my needle, it is in coaxial view, exactly along the X-ray beam. The tip and hub are in plane, so it is appearing like a dot just lateral to SAP. That's the target, and we have achieved. Now we will go inside, and here there are 3 Ds which you have to remember. Direction, you will know in AP view. Depth, if you want to know, you have to take a lateral view. So this is a target we have achieved. See, now what is happening is, I am hitting the lateral border of SAP. So I have to slip to the lateral border of the SAP. Now SAP is almost like this. Now let us imagine the SAP is like this. My needle is hitting like this, so I have to slip it. So now I will use the the bent tip in order to navigate, steer to the lateral border and then go underneath the SAP. Now what I am doing, you see my slot is towards the lateral side. So needle will try to move medially. So what I am doing, I am making the slot towards medial side so that the tip will go laterally. You see, I am pushing it little. Now after pushing little, again I will check. I am going, my hub is going again lateral and hitting. See, I am hitting still I have to slip. So again I am making my hub towards the slot towards medial. I am pushing inside. See, I push a little more. Again I am checking whether I am hugging the SAP or not. So I am going to do this maneuver 3-4 times till I slip. See, now I slipped. Now I will take a lateral view. So let us take a lateral view. Now you see, C-arm is placed in lateral in order to see the depth. We have gone just from lateral border of SAP and slipped medially into the intervertebral foramina. Now you see the lateral view. This is L4 body, this is L5 body, this is intervertebral disc. And you look at the foramina, this is a pedicle, L4 pedicle, this is L5 pedicle, and this is the intervertebral foramina. So you look at here also, this is intervertebral foramina. This looks like a keyhole. So when you are doing a trans-Kambins approach, your needle should be low in the keyhole, not high in the keyhole, because your exiting nerve root will be going like this. So if the needle is high up, it may hit the exiting nerve root. So it should always be low in the keyhole and just anterior. This is SAP. You see, this is SAP. So just anterior to the SAP. And sometimes the problem is, if there is a huge disc herniation, it may pierce inside the disc. So that can cause discitis, because if your sterility is not that good, a small skin tag which has got staph aureus and staph epidermis, even your scrubbing is not good, the skin tag is passed into the disc which is avascular. So that can lead to discitis. That's why you should be very, very cautious when doing a infraneural or Kambins approach or suprapedicular approach. You getting my point? So if there is a huge disc, then we try to do a subpedicular approach rather than a suprapedicular approach. So our position is absolutely normal. Now we will give 𝗖𝗘𝗘𝗣 dye and check. You see, this is a three-way extension line. It has got a 𝗖𝗘𝗘𝗣 dye which is diluted. This is 350 milligrams per ml. It is diluted in a ratio of 30:70. 30 is the contrast, 70 is the normal saline. And once the target area is reached, I am injecting only 0.2 ml only. Why? Because I am not sure that my needle is exactly at the target area. So if I give too much dye, the area can get obscured. If I want to do redo procedure, then your fluoro should have at least digital subtraction facility. Otherwise, you can no more do the same procedure at the same area. So that's why I advocate giving only 0.2 to 0.3 ml and check the fluoro in lateral first, so that you can know few things, whether your exiting nerve root is delineated or not, whether there is any intradiscal spread, or is there any psoas shadow. Everything you can make out with the disc, with the dye, that's 𝗖𝗘𝗘𝗣𝗑 dye. And second point is, people ask me, can we do in real-time fluoroscopy? I don't advocate doing it in real-time fluoroscopy. The reason behind is, if you do real-time fluoro, you will end up in too much of radiation. So I advocate giving 0.2 ml, wait for 8 to 10 seconds and take a shoot. So meanwhile, if the dye is intravascular, it will get disappeared. If it is intrathecal, it get diluted. If it is exactly in the epidural space, it will stay like that only even after 6 seconds or 10 seconds or 20 seconds. So wait for some time and take a shoot. So you end up in less radiation. Now take a shoot. Yes, beautiful. After 6 to 8 seconds, we have taken the image. It is in the anterior epidural space. There is a dye spread. After giving 0.2 to 0.3 ml, it has not gone intradiscal. It has not disappeared. After 8 to 10 seconds, it means that it is there in the epidural space only. And even the exiting nerve root is delineated. Now I will give more dye and see. Giving 0.2 cc. We are given more dye. You look at here beautifully. If you look at here, this is L4 pedicle. The nerve which is coming under the pedicle is L4 exiting nerve root. Look at here, this is L5 pedicle. The dye which is spreading here is a L5. This is L5 traversing nerve root and it is exiting here. So this is nothing but the Kambins area between the exiting L4 nerve root and traversing L5 nerve root. So there is a nice spread, and if you look at here, there are small dots also. They are nothing but the fat globules which are unstained. So how do we confirm that the needle is exactly in the epidural space? 2 points. One is the fat globule appearance, number one, and number two is the dye spread which is coming out of the intervertebral foramina. Because if it is intradural, subdural, the spread will not come out of the intervertebral foramen. That is number 1 point. And even with small dye spread, it spreads to higher levels. If it is subarachnoid, it will never ever come out because the dural sheath will end almost just at the entrance of the foramina. So, and the dye gets diluted in the CSF. For example, if it is intravascular, the dye have aberrant spread and it will get disappeared also, even if you are doing in real time fluoro. So, sure shot, it is in the epidural space. I am telling you again, this is L4 exiting nerve root and this is L5 traversing nerve root. Again, it is exiting under the L5 pedicle. So, on the left side, we have got a beautiful image. And if you look at here, you can zoom here, and this is L4 exiting nerve root and this is L5. You can see both of them. This is nothing but the Kambins triangle. So this is nothing but normal saline. After negative aspiration, I am flushing the normal saline in order to flush away all the inflammatory markers. And the advantage of Kambins or transforaminal epidural is we are trying to infiltrate the saline or the medication exactly in the anterior epidural space where the pathology is there, that is anterior epidural space. Now I am injecting, this is ropin 0.2%, which is a long acting local anesthetic which is mixed with 𝗣𝗕𝗓𝗏, which is a particulate steroid. Better avoid injecting particulate steroid above L3 level. This is given even in the literature also, because these are particles. Even your triamcinolone is also a particulate, your betamethasone, the so-called betamethasone is also a mixture, and it also has got, it is also particulate. So if you want to be safe, use dexamethasone. Now you see I have aspirated, it is negative. So each level you can inject almost 2 cc of mixture of ropivacaine and dexamethasone or 𝗣𝗕𝗓𝗏. Each level you can use 2 ml. For example, you are trying to attempt for 2 levels, you have to give 4 cc. A mixture of ropivacaine or bupivacaine 0.2%, which is sensory dosage, along with either dexamethasone or methylprednisolone or triamcinolone. If it is below L3 but above L3, you know about the artery of Adamakis and all. So in case if these particles goes into and block the vessels, it can lead into anterior spinal artery syndrome, which is documented. So we should be very cautious. The procedure is coming to an end. Once it is done, we are going to keep the patient for next 2 hours for observation. It's a daycare procedure. We can send the patient home after 2 hours.